Hello and welcome to the 51st session of Pediatric Orthopedic Advanced Learning Session. The aim of POALS is to expand the horizon of our fellows by exposing them to the world authority on the subject. It's our pleasure to have Dr. Benjamin Shore with us. He's a consultant at Boston Children's Hospital. All of you know that it's one of the top-ranking children's hospital in USA. His focus of practice is cerebral palsy and other neuromuscular conditions. Ben learned cerebral palsy mainly during his fellowship training at Royal Children's Hospital, Melbourne, from the doyen of cerebral palsy, Professor Kirk Graham. And you will see in his talk that there is a lot of influence of Professor Kirk Graham in his thinking. Currently, Ben is very active at American Academy of Cerebral Palsy and Developmental Medicine and also at Pediatric Orthopedic Society of North America. He played an instrumental role in forming the guideline of hip surveillance in North America. The topic for today's session is how to manage a gait with knee flexion in cerebral palsy. We all know that knee flexion and equinus are the two commonest gait abnormalities which we see in our practice. And in this session, Dr. Ben Shore is going to explain when and why to intervene. And the most important is how to manage the knee flexion gait. So I'm sure that this is going to be very useful to us. Before I hand over to Ben, I would like to give you a short introduction of 3 minutes about a new program which we are going to start soon. So I will share my screen and tell you about that program. Okay, so this is about the short introduction about the new program. You all know that Pediatric Orthopedic Active Learning Sessions is now completing 2 years. And in 2 years, we had 50 lectures. Last month, we had 2 great lectures by Professor Benjamin Joseph and Professor Vincent Mosca. These lectures are very effective for increasing the knowledge base of our fellows. However, these lectures do a very little in developing the thinking skill of our fellows, which is one of the important aim of our sessions. So now the question to us is how to develop the thinking skills. So we are starting a new program, and that program is to develop the critical thinking skills. How we are going to achieve this aim? So let me tell you about the mechanism of actions. We are going to put forward a higher level questions to our fellows, and they are going to prepare their answers on that. And these questions, they don't have a clear-cut answer. So naturally, they have to look at the pros and cons of the situation, and then they have to prepare a short presentation. And we are also going to cover real life problems, because in practice, in operation theater, when we come across a problem, unexpected outcome, or some complication, in that case, we really have to make an important decision. And how to make that decision, that we are going to teach them. So these sessions are not going to be like watching or listening to the great person like Virat Kohli, but these sessions are going to be something like teaching how to bet. So that's a different than the current session, which we are already continuing. But in addition to that, we are going to add this session. The first inaugural session will be on Monday, 2nd September. And I request whoever is interested in developing their thinking skill should join and take advantage of this group. If you are interested in this activity, in that case, you can WhatsApp me on this number 97129256000. And with that short introduction about this program, now I hand over to Dr. Ben Shore for his deliberation. Over to you, Ben. Thank you.
Okay. Let me just get my screen up to speed here, guys. Darren, give me a thumbs up. You can see what I'm showing. Okay, great. All right. Well, thank you for the introduction and the opportunity to talk to you to guys today. It's evening there. It's around the middle of the day. I was explaining I'm in the middle of 3 cases today. So, you as a surgeon, you never want the turnover time to be long, but I'm hoping it's going to be just long enough today so I can finish this presentation, which I'm certain it will because we're kind of slow at our hospital. Just to give you a little bit of background about myself, I grew up in Canada, although I'm living in Massachusetts. I grew up in the green part of Canada. I went to school out in the pink part, and my wife is from this purple part over here. But now I live in Boston, and I actually just got my U.S. passport, much to the chagrin of my Canadian parents. I did my fellowship in the Royal Children's Hospital in Melbourne between 2008 2009, and this is what the hospital looked like back then. This is the hospital now, and it is spectacular. So if you have not been to the Royal Children's Hospital and have the opportunity to be in Melbourne, I would strongly suggest going. It's probably one of the more spectacular pediatric children's hospitals around. I went there to learn about CP, but I didn't read the fine print. I was really looking to learn how to go surfing and looking for the endless summer. I didn't read the fine print, which said that I was on call with the residents 1 in 5 nights. And so these were my fellows at the time, and it was a great experience, and it wasn't all that bad. I worked pretty hard. In my first month, I met this lovely lady in the operating room who's also another Canadian. She's a pediatric dentist, and we were working on the same patient, and we've got 2 kids now and 2 dogs, and so it all started back in Melbourne. After my fellowship in Melbourne, I came to Boston to learn from these giants in pediatric orthopedic surgery. I'm in the back here in my first year. I look a lot older now, but it was a great time. And what I'm going to talk about are really not my words, but words of these giants that I've learned from along the way. And it's just important to recognize the contributions of all of them. And just to finish up, in pediatric orthopedics, we go through these oscillations. So, I've only been in practice for 15 years, but it's really been quite a trip over that period of time, and things have changed a lot. I will acknowledge that taking care of ambulatory children with cerebral palsy is difficult, and it's hard, and you need to give yourself time to understand what's going on. And I know that you guys all are clinically extremely busy, and trying to find the time sometimes to think about a patient or a case is difficult. And all I would say is to try and take a video on your phone, or be able to kind of walk away, not in a busy clinical setting, and try and put together a surgical recipe for the patient. Just because sometimes in clinic it can be a little bit overwhelming, and you can make a mistake when you don't mean to. I would acknowledge that my indications for bony extension osteotomies or distal femoral extension osteotomy and patellar tendon shortening have narrowed tremendously with the advancements of anterior distal femoral hemiepiphysodesis. And so we'll show you some cases, but this is one very early child that had anterior screws, and actually just 2 weeks ago, I had to reinsert the screws after he made full correction, took the screws out, and then he just, as his adolescent growth spurt, developed just a little bit of residual contracture, and so new screws went back in. And so we'll talk about some of the work that we've done here. But if we think about what the outline is, and I apologize if the videos are a little bit jumpy, but we'll do our best with the limitations of Zoom. But we're going to go over some things which may be review, and if so, I apologize, but we'll just talk a little bit about normal knee function. Excuse me, I'll review common gait deviations as they apply to flex knee gait, talk about some treatment options and some POALS, and then we'll have 10, 15, maybe even 20 minutes for discussion, which I hope you all participate in. So I think if we start at the beginning, the knee is a complicated joint. And if we think about how the knee works relative to gait, it's not just the knee. And I think what happens where we fall into mistakes is we only look at one joint, but in really there's many moving parts that are working in conjunction to make gait efficient and functional. And so this would be my plea to tell you, don't just look at the knee. And as Dhiren said, it's the ankle and the hip in concert and how they work together. Excuse me. So if we just look at normal knee function, I'm just going to go through the gait cycle very quickly. We have our loading response, which is really the first flexion, or what we would call shock absorption of the knee. As the foot hits the ground with our heel strike, there's an initial shock in the beginning of stance. And then as you work into mid stance, the knee should get close to zero. And that's often where we start to see there are knee problems, because the knee's not getting to terminal extension. It's important to realize that a knee may not get to terminal extension not only because there's a knee problem, but there can also be a problem, as we talked about, at the ankle or the hip that can contribute to that. We then move on to mid swing, and this is kind of the acceleration or the pendulum activity of the knee as the knee starts to go through its second flexion to facilitate clearance of the ankle. And this is a rapid phase that can be sometimes affected by muscle spasticity, in particular the rectus. And then as you go through terminal swing, the knee is swinging through to get ready for another heel strike. And so at this point, we're preparing ourselves for initial contact. And you can see here the knee is decelerating and coming back to terminal extension for that first initial shock absorption. And the knee goes through these motions. And the reality is that for the knee to do that coordinated movement, there needs to be coordination of muscles above and below the knee that are turning on and turning off. And as Kerr taught me, CP is about the tortoise and the hare. So kids grow at a normal rate, but their muscles have a problem with reacting to that growth. And so if we think about the tortoise represents your muscles and the hare is your bone. And the bones are just kind of going, and you go through these growth spurts, and then the muscles have to catch up. And it's often, remember, those muscles that cross two joints that are most affected in CP. And I apologize, my throat's a little dry in my office because it's hot here, and my partner likes to keep the AC on really, really high. But when we're thinking about the management of flex knee gait, a lot of it is pattern recognition. And when we're looking at pattern recognition in CP, there are certain patterns that we want to try and identify. And not everybody has a gait lab, but almost everybody has a phone. And there are all sorts of different free and available applications. I use this one called Huddle. But this is actually a sports application that you can film and slow down the frames to 1/1/8 of a second so that you can really start to see where gait deviations are occurring. But for the trainees that are listening, video patients that are confusing, because if you can break down the video and look at it when it's quiet and look at each joint separate first, you'll start to understand where patterns are and where pathophysiology exists. And so when we think about the knee patterns that are commonly seen, we see sometimes cospasticity and hyperflexion, which is often seen at loading response. And that's because there's too much going on. Certain muscles are turning on and off. We have those pictures that we've seen from Jim Gage's textbook with the red light and the green light and the traffic lights. But what happens in CP is instead of being coordinated, it's all on in cospasticity. And so you see this increased flexion at the initial contact. In mid-stance, kids don't get to terminal extension, and they often don't get there because they have various degrees of lever arm dysfunction. And remember, lever arm dysfunction is related to torsional abnormalities through the ankle, foot, and hip that are affecting the plantar flexion knee extension couple and the ground reaction force, which is coming up through the ankle. And finally, if you see that decreased peak knee flexion, which is what we talked about, where muscle spasticity, primarily the rectus, is the culprit, which is leading to decreased and delayed peak knee flexion. These are all areas and patterns that we want to try and identify and look for when we're trying to put together our surgical recipe for pathophysiology. And finally, the loss of heel strike. Remember that if you're seeing a loss of heel strike in a child who walks with the flex knee gait, it's not always because their Achilles is tight. And for the trainees, whenever I show a video of crouch, they think the Achilles is tight because the foot's not getting a heel strike, but that's the first trap, right? If you have a knee flexion contracture, you can never initiate a heel strike because you can never get your heel out in front of you. And so it's just important again to remember the relationship between the hip, knee, and ankle. So as we said before, clinic is busy and chaotic. Take down a video, find time to review it when it's quiet, and you can actually think about where all the gait deviations are occurring. Now, when we think about gait deviation, Sutherland and John Davids first described these 4 different gait patterns of jump knee, crouch knee, stiff gait, and recurvatum. Excuse me. And what they broke down is that through the stance and swing phase, there were variable abnormalities seen in terms of flexion and pathophysiology. And then more recently, Jill Rada and Kerr Graham came up with the sagittal gait patterns that are kind of more typical. And this figure is great because it goes through 4 different gait patterns, which really show you the evolution of spastic diplegia as far as I'm concerned. Most young children with spastic diplegia are group 1. They have some spasticity and they're in equinus, but then over time as they get older, heavier, develop contracture, they migrate through group 2 to group 3 and possibly group 4. So we'll talk primarily about groups 2, 3, and 4, the jump gait, apparent equinus, and crouch gait today. Excuse me, and the surgical interventions associated. Now this paper put out by Jeff Young, who is the fellow who came after me in Melbourne, and Kerr Graham, was very helpful, and it's in the Orthopedic Clinics of North America. But this paper breaks down what's the dose, and that's really what orthopedics, or especially ambulant orthopedics with respect to neuromuscular children, is all about. And so here in this figure that's from that paper, you can see first, here they're talking about the position of the ankle. Is the ankle greater than 90 degrees, less than 90, equal to 90? Remember, apparent equinus is our trap that we'll talk about. They don't have a heel strike, but their ankle motion is pretty good. But what this slide also shows us is which muscles are affected, excuse me again, at each level, and then what brace might be the brace appropriate. So you, as a trainee, would say this figure is your gold because it goes over so many of the things that you need answers to when you're recognizing patterns in spastic diplegia. So I'm going to go over these gait patterns briefly, and then we'll talk about our treatment interventions. As I said before, jump gait is really what I would characterize as early diplegia. You have spasticity in the hips, at the hip flexors, the hamstrings, and the ankles. You can see in this child, he's kind of bouncing down the hallway with anterior pelvic tilt. And so you're looking for concomitant flat spasticity at the hip flexors, the hamstrings, as well as the ankles. And often we consider some degree of multi-level intervention, whether it's multi-level tone management or multi-level surgery. Now, crouch gait is the opposite. I would call this late diplegia. Kerr always used to say, when you're watching someone in crouch, ask yourself, is the patient falling down or are they being pulled down? And what that differentiation is important is to say, are they falling down because of weakness or are they being pulled down because of contracture? And it's not just tight hamstrings, there can be multiple causes. This girl had spastic diplegia, but also had a pretty significant spinal tether. And so she required a detethering first and then her multi-level surgery to get her into an extended posture. The clue here that we'll go over is if you look at her pelvis is tipped posteriorly. And that is a very helpful pearl from a clinical perspective as to identifying whether the hamstrings are a culprit in the pathophysiology of the gait that you're seeing. If the hamstrings you think are tight, but the pelvis is tipped anteriorly, it's unlikely that those tight hamstrings are contributing in a negative way. So when we think about the etiology for crouch gait, it can be weakness, contracture or lever arm dysfunction, as we talked about. Now, apparent equinus, this is the trap. I need to talk about it for a second, just so that you don't fall into the trap of doing more ankle surgery when it's not necessary. So you see this girl, if you're really critical, is maybe not getting complete knee extension. And when she walks, her heels never come straight on the ground despite being in a solid AFO. So your first clue that someone has apparent equinus is they're in a 90-degree solid AFO and they're not achieving heel strike. So remember, these children do not need more ankle surgery. They need treatment above stream, either at the hips because there's a residual hip flexion contracture, or something at the knees. And then finally, stiff knee gait. Stiff knee gait is associated with increased tone in the rectus and also some associated equinus. This is a video courtesy of Bob Kay. And what you're looking for here is that decreased peak knee flexion that's delayed, as you can see in the top right. And I think the goals when we talk about our treatment is we just want to make sure we do the right thing. And it's hard because there are multi-level pathophysiology. So the analogy of measure twice and cut once is really present when we're taking care of neuromuscular children. And I'm sure everyone has seen John David's diagnostic matrix, so I don't need to spend too much time there. But when we think about our interventions for knee surgery, there are these directions on your compass of spasticity, right? There's general, reversible, focal, and permanent. So if we think about our tone management options at the start, these treatments like Botox and oral medications and even phenol are relatively reversible. I recognize there's been lots of discussion and new literature demonstrating what are the negative effects of Botox. And the reality is it's probably not something that wears out completely, but we don't have a lot of other solutions to help us as kids are going through those rapid growth periods. And so cautious, judicious Botox use is probably our best option rather than early muscle tendon lengthening, which will only last for a few years. Now you have more complicated interventions like intrathecal baclofen pump, which is inserted for the GMFCS level 3s, 4s, and 5s. Very resource intensive and I bet quite challenging in India, just because it's hard to get patients to come back and a baclofen withdrawal can be potentially life-threatening. And then selective dorsal rhizotomy, which typically is used for ambulant children. In our experience, we have started to explore what we would call a palliative SDR, which is a combination of dorsal and ventral rhizotomy for 4s and 5s, who we don't think would be good candidates for baclofen pumps. And so that, I think, needs more dosing and fine-tuning before it's brought to everyone, because I think it's a reversible, permanent, it's not a reversible intervention, it's permanent. And so you just want to make sure you're doing the right thing. Now, when we think about the surgical interventions for knees and knee flexion, there are a host of different things that we will go over. Hamstring lengthening, distal femur lengthening and transfers for rectus, guided growth, extension osteotomies, patellar tendon transfers, and patellar tendon advancement, as you can see here. And it is a little bit of a choose your own adventure or a house of danger. And I think you need to recognize how you can go wrong here if you're not careful. And it's very easy to get lost, and it's important to reach out and use your friends as much as possible to help you stay on the right path. So I think most people, when they see a child walking with their knees bent, go right to, well, it's a hamstring problem. So the hamstrings are tight. We use our popliteal angle as a measure of hamstring length. I do it myself. But in reality, it's probably not the most accurate measure of what's truly going on at the hamstring. Some people will suggest measuring unilateral versus bilateral hamstring length as a way to help differentiate how much the hip flexor tightness contributes to the pathophysiology around the knee. But as I mentioned before, I really try and focus on the tilt of the pelvis as a way to give me an idea of what's going on at the level of the hamstring. Now, hamstring contractures are quite common. The indications still are unclear, and we've written those with our Mission Impossible project. And muscle modeling often says is that the hamstrings are not tight, which is confusing because I think many of us, when we feel the hamstrings, feel that they're quite tight, and we can't really understand how they're not involved in the pathophysiology of crowd gait. By no means are these gold standard rules, but these are Shore's indications. So, a hamstring lengthening is indicated for me if they do have some tightness on muscle testing, if there is a little bit of a knee flexion contracture. But from a kinematic perspective, I'm looking for that lack of knee extension with gait and increased knee flexion, either in early stance or late swing, and posterior pelvic tilt. I think posterior pelvic tilt for me is probably the most indicative, and I would tell you that I rarely do an isolated hamstring lengthening on any child because I think it's rarely just one hamstring tightness that's causing the problem. If I'm going to do hamstring lengthening, there are a host of different ways to do it. I adopt something as a compromise of John David's descriptions of slow versus fast twitch muscles. I only lengthen the medial side structures. I stripe the semimembranosus and do cautious intramuscular tenotomies of gracilis and a tenotomy of semitendinosus. For GMFCS levels 2 and 3, I consider a semitendinosus transfer, and we'll talk about why I consider that. I would say that the risk of isolated hamstring lengthening is what you see here, which is recurvatum of the knee and anterior pelvic tilt, which is fairly common if you're over aggressively lengthening hamstrings inappropriately. And the thought is that the semitendinosus transfer prevents the anterior pelvic tilt by taking the semitendinosus and wrapping it around the adductor magnus to try and keep the pelvis in more of a neutral position. This was described by Paolo Selber in Melbourne, and it's taken from the work done in polio patients. I don't think there's been a lot of large studies that have validated the effect on the anterior pelvic tilt with this intervention. I would say that I do it not frequently, and so if Paolo Selber is listening to this, I'm sorry, but I still do it occasionally, but my indications for doing this are pretty limited. Rectus transfer briefly. The design here is that if you're seeing that delayed decreased peak knee flexion, that the rectus is the culprit, and trying to do something with the rectus to balance the muscles around the knee is what's been proposed. I think there are two large camps in terms of management of rectus overactivity. There's those that do intramuscular lengthenings, and then there are those that do a rectus transfer. The rectus surgery in general is reserved for GMFCS level 1 and 2 children who have decreased peak knee flexion that's also delayed. You can also look at the EMG to see overactivity of the rectus femoris in swing, as you can see on these two images. What I would say is that the rectus technique here is somewhat of a midline incision. You really want to elevate the rectus before you amputate it and just get into the rectus itself and not into the vastus below. You can then work through the intermuscular septum and plug it into the semitendinosus. This is not a hard surgery, but it has a fair amount of morbidity and post-operative rehabilitation. The goal is to improve knee flexion. I would say that I can count on one hand the number of times I've done this. And in my population, if I'm going to do anything to the rectus, I do an intramuscular lengthening in the distal third. And that still is done rarely because I feel like that intervention is not indicated tremendously. I'm going to spend a fair amount of time talking about guided growth for the distal femur because I think that's where people are interested. I think this is a relatively novel technique that has a lot of upside. We use guided growth throughout pediatric orthopedics with some pretty impressive techniques, primarily in the coronal plane. There's been all sorts of different ways guided growth has been described, whether you use staples, 8 plates, or cannulated screws. For anterior distal femur hemiepipsodesis for knee flexion contracture, this was described by Klatt and Stevens as well as by Metazo. In 2008, this paper found that there was a lot of knee pain with 8 plates for anterior hemiepiphysedesis, just because those plates are placed in the anterior third of the femur, and they're placed through 4 arthrotomies, which can create some pain and scarring, which limits range of motion, as seen here. This study looked at screw versus plate constructs, and Metazo described putting in these percutaneous screws, either antegrade or retrograde. The retrograde images were popularized by Ken Noonan. And the principle here, if you put the screws in, is that you're tethering the anterior physis while the posterior physis is growing. So gradually over time, the knee grows straight. Bob K's written a lot about this, as we have also through Mission Impossible. The goal here is primarily for those kids who have a moderate knee flexion contracture, about 20 to 30 degrees, and at least 1 to 2 years of growth remaining. Because this is a relatively minor intervention, the nice thing about this is it's really could be done for all different functional levels, not just for ambulatory children. And you can look at all sorts of different ways to assess how much growth the child has remaining. But I'm going to just go over the technique. So these are done with 4 or 5 cannulated, fully threaded screws. And the screws are placed in the anterior third on the lateral view. So if you look at this lateral view here, hopefully you can see my cursor. Often there's an undulation kind of at the mid-sagittal plane on the distal femur that you can see here. So the screws need to be anterior to this part. And, you know, they're described as being relatively vertical. And in reality, that can sometimes be a difficult shot, which isn't critical, but you don't want them crossing over into the other half of the distal femur. They can approach the center part of the femur, which is fine, but you need to make sure that you're getting a perfect lateral. So you need to have a C-arm drape or some sort of drape to make sure that you're getting a perfect lateral. You cannot do this by rotating the leg. That's not going to work. From a technical perspective, really heavy children who have a large quadriceps muscle and a relatively short leg from a length perspective will make this a very difficult procedure to do in terms of just getting where you need to get to. So this is showing you our kind of setup. So this is nice. It's a long, skinny kid, which is like the best child for this to be done in. And you usually make a centimeter half incision. I just did a case this morning before this, using this with 2 trainees. So you can do, if you're doing a hamstring lengthening and these screws with 2 trainees, you can get everything done in about an hour. So it doesn't take a ton of time. We usually will use a split drape and not an extremity drape. And the reason for that is that you need to hug the femur when you're putting these screws in. And often the extremity drape is not, you don't get high enough. And then if the drill is right beside the extremity drape, you'll wrap the drill up, which becomes a pain in the butt. We use a radiolucent triangle. You don't necessarily need that. It just helps elevate one leg so that you're consistently in one position when you swing to the lateral. And what we typically will do, the reality is that the most rate determining step in this procedure is getting the fluoroscopy machine to go from the AP to the lateral. So we'll percutaneously place all 4 of the screws on the anterior view, just 1 or 2 threads into the bone so that they are in the bone, and you can let go of the guide wire, but it doesn't fall out of the bone, but it's still flexible on the lateral that you can direct it anterior or posterior to get to where you want to get to. And then we'll swing to the lateral, and then the guide wire will get placed. In the metaphyseal bone, you don't really need to drill the bone, so you just measure and put the screw in on power. And the key is that we often will put the screw in 4 millimeters longer than whatever we measure, because it can be sometimes hard to take these screws out. And if you put them in flush against the femur, it's not a good day. And so there's been some reports looking at the degree of correction. And we've written a paper just, I think last year was published in JPO that talks about the degree of correction and where you want the screws. What's interesting is that I think that the distal femur grows in a circumferential pattern, so that over time, screws that you think are very anterior will migrate more to the middle of the femur. And so sometimes what you often have to do is replace your screws because they've stopped completely working. And the greatest amount of correction is seen in the first year of growth. And I think the reason for that is that because of the circumferential growth, after the first year, the screws tend to migrate a little bit posterior. But it's a really powerful tool. If you look here, what we talked about in our paper is just a way to quantify how much correction you get is that most normal distal femurs are about 90 degrees to the long axis of the femur. And you can see here that this angle now is about 115 degrees. So there's been about a 15-degree correction in the physeal angle, which tends to correlate with motion. And you can see those 4 or 5 fully threaded screws are starting to bend. It's key that you can leave them a little bit proud because it's easier to take them out. And you just have to explain to the family that if you're leaving them proud, sometimes the kids will have a little bit of irritability for the first 2 to 4 weeks when they're flexing until their body forms a bursa, and then they're fine. The nice thing is I do this for all functional levels, and you can do it early in 4s and 5s, and then it really helps mitigate the degree of knee flexion contracture. The hardest thing is that these screws don't know when to stop. So that if kids are not following up with you and you have incomplete crossage of the physis, one screw is across the physis and one screw isn't across the physis, you can inadvertently create a crankshaft phenomenon. But this was a Mission Impossible paper that I helped write that was published 2 years ago that really talked about our consensus statement related to this procedure. So anterior distal femur hemiepiphysodesis can be indicated for both ambulant and non-ambulant children. For ambulant children, you're really helping with their gait, but for the non-ambulant children, your primary goal is to help them stand and transfer easier. We say 2 years of growth left, but I would still do it if there's at least 1 year of growth remaining, because the most amount of effect that you see is in that first year. I've seen corrections up to 40 degrees, but the major wheelhouse for these screws is about 10 to 20 degrees, which is great because that difference is a real important difference in terms of making the gait a lot more efficient. It's a good indication if you've done a bony procedure and you just want to rescue another 5 or 10 degrees. But there's no role for doing this if there isn't a knee flexion contracture, and that you need to continue to follow these patients like any patient who's had guided growth. And you can consider doing combined patellar tendon advancement or shortening if you see an extensor lag when you're putting the screws in. I typically would wait until they've made a full correction and do a definitive patellar tendon advancement at that point, but you could definitely do it in both ways. And so I just show a quick case here. This is an 8-year-old boy who is from Mexico. He has Martsolf syndrome, which is like a spastic diplegia, but from a genetic etiology. Pretty significant knee flexion contracture. So before I saw him, he could not walk. He got around on his knees. He had gone to Gillette and he had gone to DuPont. His hamstrings were very tight. He couldn't stand, he couldn't walk, but he was quite bright and he had all the resources in the world, and the family wanted to do something. These are just some home videos of him. This is kind of how he got around, and he just could crawl on his knees. He really couldn't do a whole lot of anything. So his radiographs pre-op here, and he was young. Like most of the time I do these around 10 years of age, but he was pretty young, and you can see he already had some subluxation of his tibia posteriorly. He had guided growth screws placed with associated hamstring lengthening, but the hamstring lengthening didn't do a ton. As you can see, his knees are still those were his maximal terminal extension at the beginning. This is 1 year post-op. And this is 2 years post-op. So you can see a couple things. One, you can see his physeal angle has changed significantly. If you just look at how his leg is resting, it's pretty close to being straight now. So this was him walking, I think probably around a year post-op. So he's got a lot of torsional abnormalities that we never even saw before because he never was upright. And so then at about 2 years, we took the screws out and we did some lever arm correction, and this is what he's looking like afterward. So he's got more of a stiff knee walking pattern, but as far as the family's concerned, they're pretty happy that he's upright when he was only crawling with his knees. And so that was done with just 2 screws and a hamstring lengthening. And interestingly enough, this was the individual who 2 weeks ago I put the screws back in because he got some recurrent knee flexion deformity. But this is kind of what he looked like after all of his interventions. And so, I think that guided growth is really a powerful tool that can be applied to many different children with knee flexion deformity, with minimal rehabilitation, minimal morbidity, but tremendous potential for correction. And finally, I'm just going to talk about distal femoral extension osteotomy, patellar tendon shortening. Ben Joseph has popularized this, and my discussion will be a little bit of a different technique than the way he describes it and the way I'm sure many of you will do your extension osteotomies. But this is really indicated for me in those kids who are skeletally mature with a knee flexion contracture greater than 20 degrees. And really, I will only do this in a child who has some cognitive ability to participate in rehabilitation. I think if they have behavioral problems or they're cognitively challenged where they can't participate in therapy, I think you can do this intervention and take a child off their feet and they'll never get back to the being on their feet, and the parents will not be happy with you. So you just have to be quite careful about who gets this intervention. I've done it for one GMFCS level 4 who was very articulate. She was from the Middle East and she wanted to have the ability to stand pivot transfer for independence in the bathroom, which I thought was a very reasonable goal and one that we were able to achieve by bringing her knees out straight. So, the setup is pretty consistent. So we'll use some sort of regional blockade, an epidural. I use a radiolucent table. I often don't use a tourniquet anymore. This is just showing how I would position the child so that you can kind of access both legs at the same time. We use the blade plate for us because that's easy to train trainees. I think doing the way it's described by Ben Joseph is also just as powerful. We use the 4.0 cannulated drill set primarily just for the 2.7 cannulated drill bit, and that allows me to create a cerclage with fiber tape to do my patellar imbrication. And these are some images of what it looks like. I think things you need to be thoughtful about are threefold. So one, you want to protect the neurovascular structures. Always shorten because there's no harm in shortening, and a stretch neuropraxia will be not good for anybody. You have to be mindful of your rotation. Almost always when you do extension osteotomies and you are doing extension and taking out a trapezoid of bone distally like this, you inherently build in some external rotation. And so if you want to internally rotate the distal femur when you're doing this extension osteotomy, you have to be very mindful to put the chisel in the distal fragment slightly posterior so that when you internally rotate, the blade will actually sit on the femur. And so those are things that people don't think about. This is just a little schematic video showing my technique. So, a lateral-based incision here, we're just elevating the IT band and the vastus, essentially in a, muscle-sparing condition. Once you get down to the femur, as you can see here, you place a T in the periosteum if there's much of a periosteum, and then you're going to be putting your guide wire into the distal femur, as you can see here. I do a 90-degree blade, so the guide wire is perpendicular to the long axis of the femur. The chisel is impacted to match the knee flexion contracture, as you can see here. And then we're going to be loosening the chisel and then creating our osteotomy. And the first cut distally of the osteotomy will match, and the second cut will be perpendicular. That wire that you saw there is really just for derotation, so we can keep track of what we're doing. So you can see a trapezoidal piece of bone is being cut out here, and I never go less than about a centimeter to centimeter and a half, and you really have to be mindful of whoever's doing the cutting that they don't converge into the blade, which is a common mistake. That piece of bone is then removed and impacted. The blade is then placed, and the leg is in extension. And if we're going to do some rotation, we correct rotation. Typically, you can't really do more than 20 degrees of rotation one way or the other with an extension osteotomy like this. I think if you go a little bit higher in the metaphyseal supracondylar region, I think you can get a little bit more rotation. Here we make a small drill hole and poke hole in the patella, and we use our 2-7 drill to drill across the patella and create a hole. And this will allow me to do a cerclage. So I do a patellar imbrication. I think that's quick and simple with minimal morbidity. So we're just shuttling through a Houston suture passer here, and then we use Arthrex fiber tape, which is a little bit wider than the fiber wire, and that has a less chance to actually kind of saw through the patella. So we're through the patella, and then we close the rest of our femur wound. And once that's done, we then make our anterior approach to the patella and patella tendon. We come down through the patella tendon. We open up the tendon sheath, as you can see here, and then we're going to shuttle down those two limbs of the fiber tape from proximal to distal. So those are being shuttled into our anterior knee wounds, as you can see here. And we sometimes will just pull them back and forth just to make sure there's no soft tissue bands that are holding up our cerclage. And then we'll create a drill hole just distal to the tibial tubercle. And you can see the redundancy there already in the patella. So we place this from medial to lateral and then shuttle from lateral to medial. And we're going to bring our stitch back over, and then we'll tie this stitch down, and this kind of sets our tendon position and our patella position in a relative Baja spot. So we tie this with the inferior pole of the patella kind of sitting right at the tibial spine, as you can see on the schematic, and we'll put in a whole bunch of knots here. We want to at least make sure the knee gets 90 degrees of flexion, but you can see there's tons of redundancy in the patella tendon. So now we use some fiber wire, and we create an anchovy, or we just roll the redundant patellar tendon over on itself and throw about 3 or 4 stitches here, and then take that Kelly clamp away. So to summarize, I think your guide wire here wants to be in the mid shaft of the femur, not so much in the mid shaft of the distal fragment, because your blade will end up being out the back of the femur if you make that mistake. There often is some translation. Don't be afraid to take off a little bit of that bone. You can flex the knee up and protect yourself and just come across and saw or rongeur out that spike just so it's not pushing on your neurovascular structures. This was an old picture that showed a patella bone block, which is described by Gillette, and I don't do anymore because I just think it's too much surgery and it's not needed. What I do when I do this now is I really keep the knee bent for 72 hours before I straighten it, and that seems to help let the soft tissues relax. If they have an epidural, I don't let them sit more than 90 degrees of flexion, just because I've had some kids stretch their lumbar plexus because they've been so tight and they can't feel. So I usually say head of the bed to 60 until the block is out, and then we move the legs straight and allow them to sit up. They can weight bear an extension with a Bledsoe, and we start range of motion at 4 weeks. This is a great procedure. It's very powerful, but always when you're doing acute corrections, these are the things you have to be mindful of: varus valgus, stretch neuropraxia, and to a lesser extent, wound issues. So I think there's really been an evolution in knee surgery. If we think about the first generation, we did a lot of soft tissue interventions, psoas over the brim, hamstring lengthening, ground reaction AFOs. That was our first generation of knee treatment, probably in the late 90s, early 2000s. And then our second generation started to involve bony correction. So we did some soft tissue lengthening, and then we started to do our distal femoral extension osteotomies and combination of soft tissue lengthening and bony osteotomies. And now our third generation has some of these more eloquent things, which is guided growth, which I think is a game changer as far as I'm concerned. and some judicious soft tissue lengthening. So I guess if I'm going to conclude, to make sure that there's enough time for discussion, I think it's important to recognize that there is a plantar flexion knee extension couple in place here, and that if you only look at the knee, you're going to make a mistake. And so you have to really be mindful of the hip, knee, and ankle together. Isolated hamstring tightness and lengthening is rare. So if that's your recipe, just double check and make sure you're not making a mistake. Guided growth is great. I would strongly suggest thinking about becoming one of those people that does this, but you have to recognize that there are some pitfalls, and you need to make sure that patients recognize they need to follow up with you every 6 months with recurrent radiographs. And extension osteotomy works, in particular in skeletally mature children, but just make sure that you pick the right patient and to make sure that they have good functional goals that can be achieved with your extension osteotomy, because it can be associated with a fair amount of morbidity. Thank you very much for your time. I'll entertain questions at this point and stop sharing.
Yeah, Ben, thank you very much. Now, the first question I have is, like you mentioned that the latest we can do the guided growth when the 1 year of the growth is remaining. What about the earliest age?
Yeah, that's a great question. So I think it depends. The earliest I've done it is about 8. I think the reason why I wait is because, sometimes if it's a small physis and you put a screw across it, it may shut the whole physis down. You don't know. And if you do that, at 6 or 4, then they're going to be very short, right? And so I wait at least till 8, because I think the size of the physis is big enough to not take too much of a hit. And that child has continued to grow very nicely in the youngest. But so those are the reasons why. So I don't really go younger than 8. And that's just because I'm afraid of creating an iatrogenic growth arrest. When you put the screws in, you'll see the physis does start to get narrower. And so I'm just worried about that.
Okay. What about the if you put it at 8, by 10 you would require to remove it?
Yes.
What about the recurrence?
So I think that what we tend to do when and this is the hard part, this is the more of the art of what we practice. So what I tell families is I make sure they all understand when they come to clinic. I demonstrate hyperextension with me. So I say, if you see your child locking their knee in hyperextension, please reach out to me, because that's an indication that we need to take them out. But I often will let them all get into just a little bit of hyperextension, and then that residual tightness that they get afterwards kind of balances it out pretty nicely. Now, I've been doing guided growth for about 7 years pretty religiously, and I'll say that I've only revisited the guided growth once so far. But I think if you start to do it younger and younger, the likelihood of needing to revise it is higher. And what's interesting is that, how I showed you the physis changing the angle, it grows back. So once you have about 2 years, and I haven't written about this yet because I just don't have enough patients that have gone through that, but once you have 2 years of taking the screws out, the physeal angle tends to normalize, which is just, just amazing how the body grows.
But in that case, does it lead to flexion deformity again?
So, this one child I did it in recently, their knee flexion, it looked like they had about a 10-degree, maybe 15-degree knee flexion contracture when they were awake. But when he went to sleep, it was only about 5 degrees, but I still put the screws in because I think for these kids, if you can get them straight or just a little bit hyperextended, you'll see their gait is much better. And then they can tolerate a solid AFO or ground reaction AFO. Whereas if they have a 10 or 15 degree knee flexion contracture, they'll never tolerate that type of a brace because it pushes them back and they lose their balance.
Okay. Usually when we carry out a distal femur extension osteotomy, we combine it with patellar tendon shortening. Now, how do you combine this patellar tendon shortening in case of guided growth?
Yeah,
do you do it when you remove the screw, or you don't do it?
Yeah, so there's two, so it's a great question. There's 2 schools of thought here. So Bob K, if he sees that there's an extension lag of greater than 20 degrees, he will do it concurrently with the screws. I kind of think that's flawed because you're going to bring the leg into more extension. So whatever you tension the patella to, it's going to be more extended in 2 years, and so you're missing the boat. So I have done it once they've made a complete correction, and there's that extensor lag. So extensor lag is one of the drivers for me, and I do it as a secondary intervention.
Okay. Then there is a question like, have you noted any difference in two sides of correction if you're doing it bilaterally?
Yeah, it's a great question. So often, most kids, we all know, right? They're not the same in terms of their degree of knee flexion, right? So one will be a little bit less and one will be a little bit more. And so what often happens is that the one knee gets straight and the other knee has not completely straightened. And what you'll notice if you're really critical about things, it's usually after about 2 years. And the one leg is straight, so it's time to take those screws out. And when you look at the other screws, like we talked about in the lateral plane, the screw will have migrated slightly. So it's not so anterior as how you put it in at the beginning. And so sometimes it gives you an opportunity to take that screw out and just reposition it when you're taking the first ones out. But I tell parents that, look, your deformity is worse on one side than the other. I think that's what I see more than differential correction, but it's a great question, and I don't know if I can tease it out because they start with a differential degree of knee flexion, and then they might have a differential rate, so there's too many variables, so I don't really know, but I've definitely seen the scenario where one set of screws come out before the other. And I think you just have to be, go ahead.
So that's basically like something when there is a difference in the valgus on both the sides.
Exactly the
we
same
remove
scenario.
the screw on one side earlier than the second one. Then there is a question like, have you got any case of excessive or progressive hyperextension even after removal of the screw? Means like the permanent.
No, I haven't seen that yet.
Yeah, okay.
I haven't seen that yet. But I'm hyper vigilant about that. I think if you're not careful or if your patients don't always follow up with you, I think that's the one risk with guided growth, right? Because they go away, right? And I know sometimes it's hard for follow-up, right? So they go away and the screws aren't going to stop, right? So that's, I think, something you have to be mindful of, however you do your checks and balances. I think that's what I tell families is like, even if you fire me, you have to see somebody.
Okay. Then there is a question. Have you noticed any late angular deformity following distal femur extension osteotomy?
So I think that's why the extension osteotomies have been described using locking plates as well. And in our institution, we really try and let the trainees do all the surgery, and I just like kind of guide them. But the problem is when you have like a cluster of screws that you have to put in the distal femur, you have to be hyper vigilant because all they need to do is diverge 2 of those screws, and then it kicks it into an abnormal coronal plane. And I feel like with a blade, it's like one guide wire, and once that guide wire is in, then I know I'm good. And so I feel like it's easier for me to make sure it's more accurate. Since using a blade, I have not seen that.
Okay. See, like I am using, or like say, most of us are using a distal femur extension osteotomy of a Synthes variety. And I must admit that in some of the patients, we have ended up with a coronal plane deformity, not the sagittal plane deformity, but the coronal plane deformity. So that is one of the problem. And when you are not using a locking screw, because the plate or the implant which you are using is not having a locking screw. So you don't have any method or means to correct coronal plane angulation.
It's really hard.
You
can only correct it through the osteotomy.
Exactly.
Yeah, and that's hard to do, right? Because it's also hard for a trainee to maintain. The most common thing that a trainee does is as they're going through the most of the femur, the tendency is to abduct the arm and converge into the blade or converge into the screw cluster. And then you look at it and you're like, oh, geez. Because the bone pieces, then they try and touch, they're like sitting like this, right? So I think we've all been there. And that's also why an extension osteotomy is tough, right? And you have to just be hyper vigilant.
Okay. Do you have any thoughts about the internal brace instead of screws or 8 plate. Internal brace.
Maybe
Yeah,
actually
Abhay,
I
can
asked the
you
question.
Yeah,
Yeah, maybe I could just kind of clarify. So there is
sure.
some thought about using the internal brace rather than the anterior eight plates, the one from Arthrex. So in they because it's low profile. Do you have any experience? It's I think Rachel Thompson's done a few, and there is
Yeah.
thoughts about a multicentric trial in Australia to use that rather than using anterior eight plates because it's low profile, and at least in Australia the cost profile is similar. Do you have any thoughts about that as an
Yeah,
implant
so I
choice?
would, yeah, so I think, so I would tell you that I don't use the plate and screws because I think it's associated with greater morbidity and it takes more time. As I talked about before, we just did one in my first case this morning with two trainees that have never done it. And so we did hamstrings and screws, all done, all said and done. That part of the procedure was done in 1 hour. And so it's fast, efficient, and it works. Whereas the internal brace could work. We've used the internal brace with some myelodysplastic feet. You know, most myelo kids have this like valgus. And so we've tried to use the internal brace, the Arthrex internal brace on the medial side of the foot to recreate kind of a medial pull to try and help correct the valgus deformity of the foot. And we have not been particularly impressed with the ability for that to do that. And so we are not super keen on the internal brace, but that doesn't mean it doesn't work. It's just in my hands, the screws seem to work pretty good.
Okay.
Dr. Deeran, can I ask one question?
Yeah, please.
Yeah. Hi, Benjamin.
Hey, how are you?
Hi, Gupta here. Yeah. So I was asking the question about the late angular deformity. I faced in one patient where I did a DEFO. It corrected beautifully on table. And then in between the patient was lost to follow up. And I see the patient around 4 years later with bilateral valgus deformity. So have you ever faced this sort of situation?
No, I haven't from using an acute correction. Were the plates, did you leave the plates in?
Yeah, the plates were left inside. The patient never
Yeah.
came for a follow-up.
Yeah,
He
so
was
the
doing
only,
well until he came with about 40 degrees of valgus on bilateral side, both sides.
okay.
So about 4 years down the line, that was the
Yeah.
situation. So this was a
So,
little
yeah,
puzzling
so
for me.
I haven't seen that. I have not seen that. But we've written about how plates on the plates on the lateral femur. Sorry, I don't know. Okay, I'm just getting paged. Plates on the lateral femur for trauma can create a valgus deformity. And so perhaps the plate had created some sort of tether near the physis in the growing child that kind of, it grew like that, but I haven't seen that. The big thing that I've seen is when you put screws in, sometimes they grow off, right? When you're using guided growth screws. And if they grow off asymmetrically, it creates a very difficult coronal plane deformity that's hard to correct. So I've seen them grow off on the medial side, but still have purchase on the lateral side, and it creates this crankshaft valgus at the knee twice. Now, often in like low demand patients, so it's not the end of the world, and it can be rescued with an 8-plate if there's enough growth remaining, but you just have to be super mindful of it. And the challenge is that the AP X-ray you won't see it. Because of their residual flexion, they don't get a great AP. So it's all about the lateral X-ray. So you need to have a good lateral and just make sure your screws are across the physis. Because if they're not across the physis on one side, you'll create this coronal like crankshaft, which is pretty difficult.
Thanks.
Yeah. Then you mentioned about the Kirk Graham's concept about the patient being pulled down. And so how do you judge that clinically?
Well, I think it's it's hard, but I think it's the age-old question of, is this spasticity or weakness, right?
Yeah, but
Like,
how do you decide it clinically?
Right. Well, I clinically assess their voluntary muscle control and see, whether they're able to actively extend their legs. I try and see if they have increased tone. Like even if they have a knee flexion contracture, if they don't have any spasticity, then likely that knee flexion contracture is more likely from weakness and never being able to fully extend their leg, as opposed to untreated spasticity that develops their contracture. So it's not foolproof, but I try and differentiate with their muscle control. Like, are they able to actively fire against gravity, and do they have, what's their Ashworth score? Like, are they really spastic, or do they just have contractures and they're relatively weak and they can't get their legs straight because they can't hold themselves up.
Okay.
I don't know if that's helpful.
Yeah. Then there is a question is about the post-operative management after distal femoral extension osteotomy.
Yeah.
You mentioned that you keep it for 3 days in a flexion.
Yes.
So how much flexion? 90-degree.
Yeah, I usually, no, not so much 90. I just usually do it in whatever their pre-op flexion was. So they come in with a 30-degree knee flexion contracture, and we usually just put them in we call it a Bledsoe, like a hinge knee brace. So we just set it at 30 for the first 3 days, and then once just before the block's coming off, we then put it to fully extended.
So basically the reason of keeping it in flexion is like the tissues are a bit stretched.
The nerve. It's all about the nerve.
Right. Okay.
Because I don't know, no one talks about that, right? No one talks about those complications. And if you do enough extension osteotomies, you're definitely going to have a kid who has a neuropraxia at some point. And it's really hard to manage. And so I had a few neuropraxias early in my career from a host of different causes. And I think there were certain things that I changed to make it better. So if you're using regional blocks of any kind, really be mindful of what they're allowed to do. Like, because if a kid can't feel and then they sit up and you've shortened them so they can almost touch their toes, and if they're tight, they can kind of stretch. I had one child who I think essentially avulsed his lumbar plexus just because he couldn't feel, and he just sat right forward while he had the block in place. So that's why I limit the head of the bed to 60, and that's why I keep the knees bent for those first couple days. It's not foolproof, but in my hands, I feel like that's a way to be a little safer.
And then what is your post-operative protocol? Do you give a plaster or you don't give?
No, I just use the hinge knee brace. So after they stay locked straight in extension, they can stand in extension, but I don't start motion for 4 weeks. And that's one, so I get the wounds to heal, just because sometimes the anterior knee wounds can sometimes be a little bit weird with healing. And two, I want to protect that patellar tendon imbrication, which is really just soft tissue. The reality is, if that ever pulled out, you're nowhere worse off because you've never taken the tendon off. So you could always just go back. But when I used to take the whole tendon off, if you have a wound problem, I had one kid with a wound infection, you've taken the tendon off, like there's no rescue there, and so I just feel like this is a more forgiving way of staying safe.
Okay. I think that, there was one question which is very common in India. We see a patients with 40-degree flexion deformity. So do you come across such
For sure.
So how do you manage them?
So if they, so you can do guided growth for them. And that will help if you get to them early. Technically, it's a little hard to do because it's tough to get your images. And so what I often will do in those situations is if you hang the leg off the end of the bed, then you'll get a better AP of the distal femur to put your screws in. So that's just a technical pearl with working with radiology, because otherwise they really have to tilt their C-arm towards the head of the patient a lot to get your AP of the distal femur. But if they can abduct their legs, you just let their leg hang off the bed and it's a radiolucent table, that works. So from a technical perspective, that can help. And sometimes, I don't think you can get a 40-degree correction with an acute osteotomy. I think that's asking a lot. So I either will say to the family, well, we're going to get as much as we can safely, and it's going to help you. Or sometimes we try serial casting. I just get worried about that. And I think it has risk associated with it. So you just got to really communicate with the parents about the risk benefit profile before you do that. But, I have definitely put screws in a kid with a 40-degree correction. It doesn't always work though, but even if you go from 40 to 20, for most families, that's a pretty big win. I might have to go to the OR pretty
Yeah,
soon.
fine. So thank you
Um,
very much for spending a lot of time with us and also explaining the new upcoming procedure. So thank you once again.
It was a real honor. It's great to see some faces that I recognize in the chat. Gleason just texted me. He was on and he enjoyed it as well. So, congratulations, Dhiren, for a really, innovative way of communicating and sending information around. And I wish you all the success with this as this keeps moving forward.
Yeah. Thank you very much. Yeah.
Okay. Take care, guys. Have a nice night.
Yeah.
Bye
Thank
now.
you. Bye.
Bye. Thank you.